Okay, let's look into another hand condition, which is Flexor Sheath Infection. This is very important because it's one of those emergencies where we have to act quickly when we see in A&E. So what it is, it's a pyrogenic tenosynovitis of the flexor sheath. It's caused mainly by penetrating trauma. For example, the patient may complain, they say that they had a scratch mark while cooking, or some needle piercing, etc., etc. Sometimes the infection may spread from the adjacent area, for example, phelon or septic joint, or pulse space infection, or paronychia, etc. So what is the organism which is commonly involved in flexor sheath infection? It is a Staphylococcus aureus is the most common organism. There are other organisms which can involve, for example, gram-negative organisms or anaerobes, mainly in animal bites and farmyard injuries, and in patients who have diabetes, etc. Those who are known to have recreational drug use or IV drug abusers are more prone for MRSA flexor sheath infections. Let's look into the clinical features of flexor sheath infection. Clinically, they will give definitely a history of penetrating trauma, and subsequently a rapid development of symptoms is the key in flexor sheath infection. And the symptoms are pain, swelling, unable to move the finger, and sometimes patients may be septic too, and the feeling of unwell, feeling feverish, etc. And if you look into the clinical features, of course, the observation, they may be tachycardic, sometimes there may be other parameters of sepsis as well. In addition to it, the hand examination per se, if you look into it, if you look into the finger, it will be swollen. It's like sausage type swelling, and there may be fixed flexion posture of the finger. And then if you try palpating, there may be tenderness along the flexor sheath, and there may be pain on passive stretching of the tendon as well. These four symptoms are called Cannibal signs, and they are key to the diagnosis of flexor sheath infection. So what are the investigations which are useful? X-rays, just to rule out any foreign body or any fractures, etc., which is very rare. MRI sometimes may show inflammation of the flexor sheath. Some rarely ultrasound is requested if you have time before theatre, just to see the extent of collection. But when you see the patients in A&E, there are a few things which must be done. For example, blood test, full blood count, CRP, ESR, UNEs, etc., and also blood cultures from two sides, and other laboratory tests to assess the sepsis. For example, lactate. If the patient has a physical parameters of sepsis, then probably a quick ABG would be helpful as well. Then admit the patient, hydrate, and subsequent things needs to be started. So how to treat flexor sheath infection? It's an emergency condition, so there's nothing like sending the patient home. So all patients need admission. You admit the patient, start the treatment of sepsis, for example, IV hydration, etc., and then elevate the limb, splint it. This is called conservative measures. These things are started only in very early case. For example, if the patient has some scratch and the symptoms have started in last 5 hours, it's not like a full-blown case of flexor sheath infection. Then only you do the conservative measures. And you do all these things and start on IV antibiotics as well, according to your hospital protocol. Generally, it's a broad spectrum IV antibiotics. In clinical practice, in majority of the cases, it's mainly the treatment is mainly the operative treatment, and because most of these patients have a full-blown clinical pictures of flexor sheath infection, and they rarely respond to conservative measures. So the operative treatment involve surgical drainage of the flexor sheath. This is done by 2-incision technique. for this, understanding the anatomy of flexor sheath attachments are useful. So the flexor sheath in the hand, there are 5 fingers and there are 5 flexor sheaths. The flexor sheath of thumb extend to the thenar eminence bursa as well. The little finger flexor sheath extend to the ulnar bursa, and those two communicate on the top of the flexor retinaculum is called horseshoe. If the abscess in this area is called horseshoe abscess. Any infection of this little finger or thumb can extend proximally up to this area. So if there is a release of flexor sheath infection of the little or thumb finger, should involve incision over the thenar and hypothenar eminence as well. But whereas the flexor sheaths of the index, middle and ring finger extend only up to the MCPJ, so we don't need to make an incision, separate incision here, but their incision will be one at the level of distal phalanx and one at the level of MCPJ somewhere here. The cruciate incisions are made, and you irrigate and wash out and drain the pus, send the pus for culture and sensitivity, and you should have started IV antibiotics already anyway. So this is the overall sort of conservative as well as operative treatment of flexor sheath infection. So in summary, flexor sheath infection is a common hand emergencies. We need to be aware of it and act quickly. Staph aureus is the common organism. MRSA infections are common in IV drug users. Clinically, there is 4 cannibal signs: swelling, fixed flexion deformity, pain over the flexor sheath, tenderness on the flexor sheath, and pain on passive stretching. Investigations of not particularly used. All these patients require admissions, IV antibiotics, elevation, splint, etc. Conservative treatments are rarely used, but only in early cases. In majority or all cases requires surgical treatment by incision and drainage of the flexor sheath and IV antibiotics.